Yeah. Just you must understand that the patient comes to you with what purpose? The patient comes to you with the hope that he has some complaints, and based on his complaints, based on illness, you will diagnose the case properly, and then according to the diagnosis, you will treat him and follow up with the treatment. So the patient comes to you in a hope to get diagnosed properly and get treated properly. So this is the purpose. This is the purpose of case taking. This is the purpose of seeing the patients in OPD or indoors. The purpose is to make diagnosis and give treatment. So how will you make diagnosis? What are the tools that is available to you to make diagnosis? The tools that is available to you is the history taking. Once you take history, you will make provisional diagnosis. Once you make provisional diagnosis, you have to prove and disprove it on the basis of guided examination first and then guided investigation. Once you have made diagnosis, then you will treat the patient. So that's the tool you have, and that's how you will apply it on the patients. So just see the words I have written, just differential diagnosis. What does it mean? Differential diagnosis means when you are making diagnosis, you will not make one diagnosis. You have to make a number of diagnoses, few, 3, 4, 5, whatever is possible based on the history, examination, and investigation. Is the whole process. The first history taking, and then examination, and then investigation. So you are not supposed to make one diagnosis. If you make one diagnosis, it can either be correct or incorrect. So you might not be right 100%. So you have, and there can be one disease can present with multiple manifestations, and one manifestation can be a manifestation of multiple disease. So you can't be sure unless until you prove it that there could be one diagnosis. So you have to make a differential diagnosis. Never say that I have made this diagnosis and say one diagnosis. You have to say we have kept the differential diagnosis of this, number 1 this, number 2 this, number 3 this, and the order of their diagnosis will be, number 1 will be the diagnosis in favor of what their maximum points. There are more chances of having that diagnosis. Sometimes it might be straightforward, sometimes it will be difficult to prove. So for that you will proceed with the next step, that is examination and investigation. Then just mind the word guided examination. What does it mean by guided examination? Guided in the sense, like when you are taking history, you have a whole Harrison, there are thousands of books, you have Harrison with you, more than 2000 pages. You will not take each and every history in a patient. If the patient comes with tuberculosis, you will not ask the relevant question about dengue, whether do you have dengue or not. So fine. So what are you supposed to ask? That I'll tell you in the next slide. What are you supposed to ask? You are not supposed to ask each and every question written in the Harrison. Similarly, in examination, you will focus on the examination according to your provisional diagnosis or differential diagnosis that you have made. Suppose, for example, if the patient presents with paraplegia or paralysis, how will you examine for the nervous system? You will compare the normal part, that means above the waist and lower limb. You will not try to differentiate between right lower limb and left lower limb. It is supposed that unless until there is, compressive myelopathy, compressive sort of illness, and there might be difference. Like in case of hemiparesis, you will compare left side with the right side. You will not compare with this small joints, small muscles of hands with the left side, right side, lumbricals, interosseous. You will not go into that detail. Left side abnormal, right side normal. So in that case, you will compare. So it is guided. How you have to examine, how far, how much details is needed. Suppose this thyroid gland is normal. There is no suspicion of thyroid abnormality. Will not give much importance to the palpation of nodule of thyroid. So you have to focus on the examination according to a provisional diagnosis. That is guided examination. That means history, provisional diagnosis, or differential diagnosis will guide you where you have to give emphasis. Similarly, in investigation, there are thousands of investigations, but you will not order all the investigations in a patient. What will you investigate? Your investigation will be based on your provisional diagnosis or differential diagnosis. Some of the investigations you will get done to prove your different diagnosis. Some of the investigations you will get to turn down any of the differential diagnosis. So investigation will also be guided. Having said that, there are few points that you have to always take care while you are taking history or examining. That are the general points that you have to follow in each patient. Then there will be specific points in history also and in examination also. So for that, how will you approach a case? So this is my way of teaching. Just remember this, keep it in your mind. Whenever you approach a case, you have to purpose of making diagnosis. What all you will include in history and examination, that is based on 3 C's. First C is case. Case means like if you are given a case of rheumatic heart disease, you have to define what is rheumatic heart disease, is it fitting into that, what is lesion, rheumatic heart disease. Then after defining will include whether it is fitting into that criteria, what is the severity of illness. For that you should know the natural history of the disease and you know what is the severity, like pneumonia, how severe it is. You know the severity scores also. Like in pancreatitis, you know the severity scores also. So you have to see clinically how much severe it is and on investigation how much severe it is. So you have to define that condition in detail. Like BP is that it is mildly raised, moderately raised, severely raised, it is patient in malignant hypertension, whatever. So you have to define that condition. If hypertension is there, how much severe it is. Then next, just diagnosing hypertension will not complete the case. You have to look for cause. What is the cause of hypertension? So whenever you will look for cause, etiology wise, like if it is a pneumonia, infection is there, it could be bacterial, viral, fungal, fine. Then causes could be autoimmune causes, infective causes, neoplastic causes. It will be because of trauma. So these are the things that when you will think of cause, etiology, these things will come into mind. And according to your diagnosis, what the diagnosis you have made, you look for the cause of that diagnosis. Then it is not always caused by some bacteria or virus. There could be just the risk factors, associated risk factors that give rise to this condition. Like in case of coronary artery disease, you have risk factors like diabetes, hypertension, dyslipidemia, history of premature CAD family. Some factors could be modifiable, some factors could be non-modifiable. So these are risk factors. So when you will think of cause, you will also think of risk factors. Then there could be some setting of the disease. While thinking of the cause, you will also think of setting of what is the setting in which disease is developing. Like nowadays you are seeing a lot more cases of mucormycosis in the ward. So what is the setting? Patient had COVID, patient had immunosuppression, patient were given steroids, patient are more immunocompromised. On top of that, patient were given oxygen, don't know how much sterilized it was there, fungal spores were there where patient was there. So this is the setting. Under this setting, patient develops mucormycosis. So there could be setting of a disease. Patient is low income group, is malnourished, is deficient in multiple nutrition. Patient is, so if patient is malnourished, he can have many diseases which develops on when patient becomes immunocompromised. So there could be a setting of disease. So once you will start thinking of cause, you will think of etiology, if any particular type of etiology, and then what are the risk factors and what is the setting of disease as relevant to the case. Then next, you have defined the case, you have looked for the cause, and then complications. Not all cases are very simple. There could be complications of the disease, like if the patient has diarrhea. Diarrhea is one thing, patient is passing multiple stools, that is diarrhea. If passing multiple times, how will you define the severity? The patient has hypotension, tachycardia, features of volume loss. So sometimes there is, continuity between defining the condition and complications. Like in case of diarrhea, you will not see hypertension in all cases. But if it is there, it is a complication. Patient can have, because of dehydration, patient can have renal failure. Renal failure you will not see in all cases of diarrhea, so it is a complication. So unless until you include cause and complications in the case is not complete. So what all you will cover in history taking, examination and investigation is the primary condition that you are supposed to look for, or provisional diagnosis, primary provisional diagnosis that you have made, then cause of that condition, then complications of that condition. So your history and examination will be based around these three C's. You always remember, and it is relevant to each and every case in medicine and all the clinical departments. So basic funda of three C's you must remember. After that, just come on to history taking. What all you will take history taking. You know what all you have to take. Then for a particular symptom, patient initially will start with history taking. Patient will give you history. The patient has this. What all you are interested to know when patient is narrating the history or giving you the history. These points for each and every complaint, it is general things that you have to include, like onset of the disease, onset of the complaint, duration, progression. This you have to take in all cases. How it started, what is the duration of the complaint, symptom, and how it has progressed over time. That might also include the reaction. Then coming on to aggravating and relieving factors. What are the factors that aggravate or relieve these factors? Like if the patient has pain of pancreatitis, patient will feel more pain when he lies down. So if the patient has, there must be some point in which patient will, like if the patient has respiratory complaint like pleural effusion, patient will have less symptom when normal lung is on upper side. So these things you have to get. Patient there can be other factors that will aggravate and relieve the symptoms, and then you have to look for the response to drugs, and then associated symptoms are also necessary. Sometimes things comes in groups, like one manifestation can be the association of other, like if the patient has raised intracranial tension, in that case you will have headache, vomiting, that is projectile vomiting. So if vomiting is there, and if there is some CNS symptom, you will also ask for headache. Is there any FND or other things? So you will always look for associated. What are the associated symptoms? Like patient has cough, then associated symptom, does the patient has a sputum? Does the patient have blood in sputum? So these are the associated symptoms that you can always have with that complaint. So these points are common that you have to take in all patients: onset, duration, progression, aggravating and relieving factors, including the effect of drugs, position, weather, other variations, and then the special points that are to be taken in the history. Like suppose you have to take the history of pain. In that case, onset, duration, progression, these things are okay. But for that, you have to also consider other points like site, severity, radiation, character. So these are specific to the pain. These things you have to consider. So on these points you will take history, you will not miss anything. Otherwise, you will miss something or the other. So these are the basic points that you will cover in history taking. After that, general physical exams. I'll tell you first the general things that you have to take. So in general, first of all, you will see whether the patient is conscious, oriented to time, place, and person. That is the first thing that whenever you approach, you have taken history, you know how much conscious it is. But in general physical examination, you have to make a scheme of points that you have to take. You can make a pre-designed performer also, so that you don't miss anything. So you have to see whether the patient is conscious, oriented to time, place, and person, and maybe memory, intellect, and speech. Then after seeing consciousness, you will look for vitals. The vitals will include pulse, BP, respiration, and temperature. In pulse, mind that you have to take pulse in all 6-7 points that you know. It is well written in Hutchinson, MacLeod, other textbooks that you have to take in all 6 points, like rate, rhythm, volume, character, synchronicity, peripheral pulses, vessel wall. This has to be included in all patients. And if you will miss anything, you might miss the diagnosis. Like if in a case a patient has pulse in only one limb, if you don't check for synchronicity, you will miss that the pulse is missing another limb. Similarly, if there is atherosclerosis, if the distal limbs you have not seen, you will miss that. So you have to take in all 6-7 points. Then BP you have to take in one limb is allowed in other cases, but in cardiac cases you have to take BP in all 4 limbs. Similarly, in respiration you have to see both rate and pattern. Rate is just the number, how much rate is there, how many times patient breathe in 1 minute, and then pattern, it is abdominal thoracic or thoraco-abdominal. You know, in male it is predominantly abdominal, and in female it is predominantly thoracic. So it is abdominal thoracic in male and thoraco-abdominal in females. Then temperature. While measuring temperature, it is a common mistake that you all people make, that patient is afebrile to touch. If patient, how did you know patient is afebrile to touch? Whether you have measured your temperature. If you have not measured your temperature, how can you compare your temperature with patient's temperature? So it is ideal to measure with a thermometer, because that is the instrument used for measuring temperature. Don't say it is patient is afebrile to touch. If a patient is hypothyroid, you will see in the coming slides. In the hypothyroid, if patient is thyroid, then patient has cold calm extremities. For them, a normal person on touching can appear to be having more temperature. That doesn't mean the patient is febrile. Similarly, in hyperthyroidism or other thing, patient doctor himself is febrile and he touches a normal patient, he might look that patient is cold. So that does not give you idea. So use thermometer. Don't say that patient is afebrile to touch. After seeing consciousness, vitals, you will come to other points like pallor, icterus, cyanosis, clubbing. Taking class. You have to take pallor, icterus, cyanosis, clubbing, peripheral edema, GVP, lymph node. That you have to see in all cases, irrespective of the diagnosis. Then you have to look for any other obvious abnormality which is present from top to bottom. Like patient has significant alopecia, patient has some scar, patient has cut marks on the face, or like patient has some deformity like saddle nose deformity, patient has enlarged thyroids. Fine. And any specific as required. Any specific means, like if you are seeing a patient of rheumatic fever, you have to look for the signs of rheumatic fever. If the patient is of bacterial endocarditis, you have to look for evidences of bacterial endocarditis, the stigmas of bacterial endocarditis. So these are the specific points as required by your differential diagnosis that you have to make. So this is the general thing that you have to take in all cases. Then any other obvious abnormality from top to bottom, and any specific as required by the your differential diagnosis that you have to look for. Like if a patient has COPD patient, you have to look for signs of failure. You will look for cyanosis, clubbing. That is included in general. But if you have to look for manifestation of SVC syndrome or something like that, that can be there in the patient, then you have to see that also as specific. So this is the categorization. So this will make your work easier to categorize your history or examination finding as per your requirement, and you will not miss anything. Then after you have taken general physical examination, you will come to systemic examination. In systemic examination, you should know under what points you have to take examination. This is the basic thing, like in thoracic or other points that you have to take in the sequence, like inspection, palpation, percussion, auscultation. This is in general. Like you will not palpate before inspection. So you have to follow the sequence, and then you should know what are the points that you have to take see in inspection. Like in chest examination, what are the most important points? Shape of chest and movement. There can be other things like inspection, you can see whether there is scar mark, whether there is anything of chest abnormality, other things, and whether any ICD is put there or not, whether there is any previous old scar, whether any site of other injury. Fine. So just hold on for a second. points, you should know all the points as I have told you. Or similarly in palpation, you have to see what are the points that you have to take. What are the additional points? So when you come on palpation, one thing that you have to remember that you will say, I have confirmed the findings of inspection or palpation. What happens? Sometimes you have seen that trachea appears to be deviated on right, but when you palpate, you will find that it's not right, it is normal, or maybe on the left. There was just a skin fold that it was appearing that it is deviated to other part. There can be other things like while inspecting cardiac apex, it appears that it might appear that the location is somewhere else. When you palpate, you find that there is a other point which confirms with the cardiac apex. So you have to confirm. So you utter one line that I have confirmed the finding of inspection on palpation. So that is very important. Like while palpating apex, cardiac apex might not be palpable every time. There can be many causes of non-palpation of cardiac apex. The most common is it is behind the ribs. And you know the method of cardiac palpation. How will you palpate? I mean, what is the definition of cardiac apex? In the definition of cardiac apex, you must remember the definition. Although while palpating, you will see it is, I mean, a sort of 1 to 2 centimeter area, but while in definition, you will look for in the brown ball, you will see it is a point of definite lowermost and outermost point of definite cardiac impulse. So each word is important: lowermost and outermost, and definite cardiac impulse. Sometimes you can have vascular palpation in lengthen patient that you can confuse with apex. So you have to, when you while palpating, you will make sure that it is cardiac apex. It is definite cardiac impulse. That means coinciding with the systole. So that's how you will declare that it is cardiac apex. Similarly, after palpation, you will come for percussion and then followed by auscultation. If you will change the sequence, you might miss some points or you might misdiagnose the case. So always follow the pattern. Like in motor examination also of CNS, you will also see that it has a sequence. I mean, you make your performa in your case sheet or notebook and follow that pattern. In examination also, you can, if you have get a CNS case, may write these points in initial 5 minutes so that you don't miss when you start examining. Like it has a sequence, like bulk, nutrition, these things you have to see, then you have to come. I mean, will not jump on to doing reflexes, or you don't jump into seeing the power. It has a sequence that you have to follow. So you can make up a forma and then follow that. That will give you the better, I mean, way of doing the things, and you will not miss the things. So after systemic, and then obviously these are the general pattern, and then specific things you will always follow that is required for the disease. Like in thyroid case, you will have to examine thyroid and other signs, like you have to look for ophthalmopathy and dermatopathy. So this was general history taking examination that you have to do. Then coming on to the topic for today, which is abnormal thyroid function. In this, you will see the thyroid function. What thyroid gland it is, you know that it is an endocrine gland, right? So endocrine glands as such secrete some hormones, and the action of hormone is at a distant place. Hormone circulates in blood and then goes to various peripheral organs, and effect is there on the peripheral organs. So it can have varied manifestation and practically can be anywhere it goes. So there are some typical scenarios in which patient can present with persistent diarrhea, cachexia, maybe weight loss. Patient can just present with CHF. Patient can present with infertility, atrial fibrillation, weight loss, diabetes, or just loss of hairs, non-specific symptoms, and you have to diagnose the disease. So to be specific, coming on to clinical examination of thyroid, how to examine the thyroid, you need to ideally have the patient seated on a stool or chair, and then you have to inspect the neck for any obvious swelling or any other abnormality. You also have to inspect while patient drinks water. Then examine the patient in a relaxed position, head is slightly flexed and relaxed, and then you have to palpate from behind. And remember the rule of fingertips. You have to palpate the gland with the fingers, like your thumbs are along the lobes, and this is in the center. You have to palpate with the fingers, and you have to palpate firmly down the trachea. You know, this is Adam's apple, and thyroid is located down from here. Then you have to look for Pemberton's sign of retrosternal goiter, in which you will see, if you ask the patient to lift the head, both hands, then you will see there is congestion of face. This is because of fullness of thoracic inlet and pressure on superior vena cava. So this is manifestation of retrosternal goiter, or maybe mediastinal lymphadenopathy, which is big. So where to look for thyroid? You know, by the knowledge of your anatomy, you know this is thyroid cartilage, and below this on precortical you have the isthmus in between connecting both the limb, both the lobes of the thyroid in the front view and in lateral view. So you know where to palpate. So clinical anatomy, you will see this is Adam's apple. These lobes are like this, and isthmus in the lower part of the lobes, it connects both the lobes, and then vessels are here. So in hyperthyroidism, you will see, if you can listen to the bruit in the lateral part of the glands. So these anatomy you have to remember. You have to palpate with the fingers like this, right? And you have to also observe the patient while at the neck while patient is drinking water. You can see in this case, this is thyroid cartilage, and here you can see that this area is enlarged as compared to the other part. So you can see this is enlarged left lobe of thyroid. So what are the things that you will look for in thyroid examination? In inspection, you can look for any scar mark or any mass lesion or any distended veins. So the things that you will look for in thyroid is size of the thyroid gland, consistency, nodularity, whether it is tender or not. Like in Graves' disease, it is not tender. However, it is subacute thyroiditis, the glands are tender. So that we differentiate between the conditions. Then in malignancy, it can be thyroid gland can also be fixed to the underlying structures. So these things you have to see in thyroid examination. Then if there is nodule is present one or multiple, then you have to look for size, number, location of the nodule, and consider that how you will see what's on which side nodule is there. And then you can look for bruit. I have told you it has to be seen in the lateral side of the lobes. And then Pemberton's sign I have already described, and the examination is not complete without examining lymphadenopathy, giving special attention to the supraclavicular and cervical lymph nodes. So in thyroid examination, these points we have to cover. Then just in short about hormonogenesis, just a slide. The physiology, you must have read it in physiology. You will see that hypothalamus secretes thyrotropin releasing hormone, which acts on anterior pituitary, which further secretes thyroid stimulating hormone. And then this thyroid stimulating hormone acts on thyroid, and T4 and T3 are released. Like majority of 80% of secretion is in the form of T4 and only 20% T3. In going into the blood, further T4 is converted into T3, and that acts in the peripheral system. Thyroxine forms is T3 or T4, and from the thyroid, as I have told you, 80% of hormone secreted is T4 and 20% is hormone secreted in the form of T3. There is further conversion of T4 to T3. So in actual, at any particular point of time, around 90% of hormone is in the form of T4. Coming on to thyroid function test, what are the tests that will measure the function of thyroid? Importantly, it is first thing to be done is TSH, then free T4. Total T3, T4 are not usually measured. Free T4, then if required free T3, then test of antibodies, and for location differentiation of causes of hyperthyroidism, you might need nuclear scintigraphy. in which radioisotopes are used, and then if nodule is there, sometimes you need to do FNSC of the nodule. So what test you will order? As per the existing guidelines, you can order TSH alone if you suspect hypothyroidism. How you will suspect? Based on the clinical findings that I'll tell you later. You will order TSH and free T4 if hyperthyroidism is suspected, and you can measure free T3 if T3 toxicosis is suspected. In follow-up, however, you will measure only TSH. Don't order total T4 and T3, and never order radio iodine uptake in case of pregnancy and lactation. These are things tests that you have to order. Most commonly you have seen, if patient gets thyroid test done, T3, T4, TSH, everything is done. So that is not required. It's not the, you should investigate on lesser investigations also. So there is wastage of money, and that does not help either. So how to interpret the results? To interpret result, we have a 9 square game in which you will see that there are 9 squares. On one side you have TSH, on the other side you have free T4. So these two parameters you have to take, TSH and free T4. Like it can be low, normal or high, both the names, and according to that you have to define the condition. Like if TSH is also normal, FT4 is also normal, patient is euthyroid. This is not hypo, it's euthyroid. See, if TSH is high and T4 is low, it is primary hypothyroidism. If T4 is high, that means thyroxine hormone are high, and TSH are high, that means primary hyperthyroidism. If TSH is low and thyroxine is also low, what happens? If TSH is increased, then it stimulates thyroid hormone, this thing. So if both are low, low in case, then it is secondary hyperthyroidism. You can just scroll down, you can see that you will give the condition. So you can use the 9 these boxes depending on whether TSH is low and TSH is low, normal or high, and thyroxine is low, normal or high. According to you will get the diagnosis. Like if TSH is high, raised, not very high, raised, but T4 is normal. In that case, you will have subclinical hypothyroid. If T4 is raised, in that case, it will be obvious hypothyroidism. So if it is normal, TSH is normal, but T3, T4 are low, in that case, it could have non-thyroid illness, or the patient might be on allotoxin if it is high. So this is the comprehensive chart in which you can see, based on the level of TSH and thyroxine, what can be the condition, whether the patient is euthyroid, or patient has subclinical hypothyroid or subclinical hyperthyroid, or the patient has primary hypothyroid or secondary hypothyroid. In case of secondary means, what do you understand by primary and secondary? We are discussing about thyroid. So if there is primary disease of thyroid, it is primary thyroid, hypo or hyper. Primary condition for that. If the disease, disease lying above, like in pituitary or hypothalamus, in that case, this condition will be called secondary. Like if case of pan-hypopituitarism, like TSH is also low. So TSH is also low. It will not produce T3, T4, so TSH will also be low or maybe normal condition, and thyroid hormone will be also be low. So that will give rise to condition secondary hypothyroidism. So primary means primary disease of thyroid. Secondary means disease above the level of thyroid in the chain you have seen at level of pituitary or hypothalamus. So you will see the thyroid hormones of these parameters are in some range. This normal range might differ from lab to lab, but in general it is 0.3 to 4, sometimes it's 4.5, sometimes it's 5.5, depending on the lab. And free T4 normal range is in the range of 0.7 to 0.1 nanogram per deciliter. So you will see, is it normal, raised or decreased based on the normal level. So you will see in hypothyroidism, in mild cases, you will see that it rises initially at a very high pace, TSH, and then it sometimes plateaus. Similarly, T3-4 initially declines and then it forms like this. So these things will increase. T3, TSH will increase and T3, T4 will decrease in hypothyroidism. Then just few words about nucleotide scintigraphy. Iodine 130, 123 and technetium 99 are used. So these are not always required in case of hypothyroidism. This is the test to confirm the hyperfunctioning thyroid. That means you will require this test in case of hyperthyroidism, not in hypothyroidism. And to assess whether the nodule that appears is hot or cold. So it is not required in hypo, it will be required in hyper. Similar is the case with FNAC. It might not be required in hypothyroid. Then thyroid antibodies, most commonly known anti-TPO antibodies, anti-macrosomal antibodies, anti-thyroglobulin antibodies, and thyroid stimulating antibodies. These antibodies are to be done in the workup of hyperthyroidism. So coming on to basic hypothyroidism. Hypothyroidism is one condition which is presents many times with very vague symptoms. So epidemiology wise, this is the most common endocrine disease, and prevalence of disease in females far exceeds the male to the ratio of 8:1. This condition is often unsuspected or grossly underdiagnosed because symptoms are very subtle and non-specific. 90% of cases are of primary hypothyroidism. This can present with menstrual irregularities, miscarriages, just growth retardation, vague aches and pains, anemia, just lethargy, gain in weight, and clear-cut cases you can have typical signs and symptoms. Sometimes situation is so vague that it remains undiagnosed for years. You must have heard sometimes that if the patient is, if with low activity patient said hypothyroid hai kya? So these are the symptoms. It is one of the symptoms. If you have less activity, patient is not active, patient appears to be not responding to things, appearing like retarded. Now, these are the symptoms. But this is non-specific. You might miss that. So in that case, low free T4 is there or TSH is high, and the condition, however, is very easily treatable to levothyroxine. So classifying, when you want to know the causes, coming on to second C, you might know to try to classify. That will give you the what category or what is the cause, or if not cause exactly, what are the types or classification of the thyroid disease. So in that case, thyroid could be of primary, that is because of thyroid disease, in which if thyroid is enlarged, you can have Hashimoto disease, which is there in around 65% of cases, or you can have iodine deficiency. It can also be drug induced or just dishormonogenesis. If thyroid is normal, then it could be because of spontaneous atrophy. It could be seen after radiotherapy and other treatment also, and it could be congenital. Like congenital, you will study in detail in pediatrics, but the disease is also congenital, that you must know, and that leads to growth retardation and other things, loss of sexual characters and other things. Then secondary or central, in which there is defect of P2-3 or hypothalamic. This is the classification in short. Iodine deficiency, just one slide. This is the most common preventable cause of mental retardation in the world. So nowadays, initially, you might have seen in the maybe villages, the ladies with large goiters. Nowadays, you rarely see such condition. This is because of fortification of common salt with iodine. So that has actually reduced the incidences of iodine deficiency. So now coming on to clinical considerations. So 5% of general population are suffering from subclinical hypothyroid. Subclinical hypothyroid, I have told you, TSH is raised but T3, T4 are normal. So there is no signs of thyroid suppression access, but TSH is raised. So this is subclinical. You can be asked a short note on subclinical hypothyroid. Then 15% of all women more than 65 years are hypothyroid, and detecting subclinical hypothyroid in pregnancy is very essential, because you will see that thyroid hormone is very important in development, child development in pregnancy also. So it is a mandatory test in case of pregnancy. And in pregnancy, you have to get TSH and free T4 routinely in all pregnant women at the beginning of each trimester, and you have to control the, correct the, altered level of thyroid, and it is essential for development of fetus. Otherwise, patient can be mentally retarded. The children born can be mentally retarded and other things. Then all persons ages more than 60 years should have this test done. Now, as I have told you, thyroid is one gland. The hormone is released from there. It circulates in blood and goes to the multiple organs. In fact, blood goes to every organ. So, theoretically speaking, it has effect on each and every organ. To name a few, there could be, it has general complaints like lethargy, somnolence, like increased sleep, weight gain, having enlarged goiter. Patient can have cold intolerance. In cardiac symptoms, patient can have bradycardia. You will just remember one thing, just when you will compare hypothyroid with hyperthyroid. So few the things are just anti to, the features are just opposite. Like you will see cold intolerance in hypothyroid, you will see heat intolerance in hyperthyroid. You will see bradycardia here, you will see tachycardia there. So there are a few points that you will see just they are the opposite. Skin temperature is below normal in case of thyroid, hypothyroid, and it might be raised in hyperthyroid. So in cardiovascular, you can have bradycardia, you can have angina, you can have heart failure, and you can also see cases of pericardial effusion because of hypothyroid. You must remember that pericardial effusion, if you have excluded other conditions, you know what are the other common conditions of pericardial effusion, like viral followed by CKD and other things. But if it is because of tuberculosis and other things, but if it is because of hypothyroid, if we treat thyroid hypothyroid, the pericardial effusion will resolve. And if you stop that, patient again going into that phase, the pericardial effusion can reappear also. So this is the thing. This can be a very rare presentation of hypothyroid, but it is there. You must be aware of. Then patient has very frequently associated hyperlipidemia and xanthelasma and other skin lesions that are manifestation of hyperlipidemia. Then patient can have iron deficiency anemia or normocytic normochromic anemia, like anemia of chronic disease. In reproductive system, patient can have infertility, menorrhagia, impotence, or increased prolactin. Very frequently in the IVF clinics, you will see that, or patient going for any infertility, thyroid test and these things are done at the very first level. So these are the mandatory tests in case of infertility clinics. Then patient can have neuromuscular manifestations in the form of aches and pains, muscle stiffness. Patient can have carpal tunnel syndromes, deafness, hoarseness of voice. This is one condition which can be diagnosed even on telephone with a hoarse voice. Someone is on the phone and with the voice you can diagnose that patient can have hypothyroidism. Patient also can have cerebral ataxia. Patient can have delayed DTRs, myotonia. Depression is one condition which is commonly associated with hypothyroid. You will see other few slides also. Patient can go into flank psychosis also. Then in a gastrointestinal symptom, you will see that there is less movement of gut, leading to constipation, ileus, and even ascites. Here it is constipation. You will see in hyperthyroidism it is diarrhea. Then you can have dermatological manifestation like dry, flaky skins and hair. Patient can have myxedema, malar flush, vitiligo, or alopecia, and even carotenemia. So So these were the symptoms. So there's a whole list of symptoms, and most of the symptoms are there in other diseases also. So you have to see the thing in toto. Like there is patient weight gain, and one thing that you will, few things that you will remember, like cold intolerance, weight gain despite taking less food, bradycardia. These things together makes the diagnosis of hypothyroid, besides other things. Then in clinical science, you can have coarse hair, which is dry, cool, and pale skin, as I told you earlier while I was telling about temperature taking. Then patient can have goiter, however, it is not present in majority of cases. You can have shortness of voice, so hoarseness of voice. Then patient can have non-pitting edema, puffiness of eyes and face, delayed relaxation of deep tendon reflexes, slow horse speed and slow movements. Then there can be alopecia and thinning of lateral 1/3 of eyebrows, which is called madarosis. Then you can have bradycardia and pericardial effusion that you can see as signs also. So you know the famous quote, what is the mind knows, the eye see. So you should know what are the things that you have to see. You have to suspect hypothyroidism when you see any psychiatric patient. Elderly patient, I have told you that 15% of them are hypothyroid. So when you see any elderly woman or man, you have to suspect it. When you see a patient of OSA, you have to suspect it. If patient has raised cholesterol level, if patient has been administered lithium amiodarone, then you have to see. Then in postpartum, woman can be there. If patient has autoimmune disease, patient can have this disease involving thyroid also. Then you have to see if the patient has features of ophthalmopathy, you have to suspect. If the patient has history of thyroid disease, if the patient has history of neck radiation. So these are the, in a way, cause, association, or risk factors that I have told you while I was describing 3 C's. So these are those conditions. When these are there, you will suspect the thyroid could be there. So just to describe system wise, when hypothyroid is there, in that case, cardiovascular manifestation, there is decreased ventricular contractility, there is increased diastolic pressure. In hyperthyroidism, you will see there is increased systolic pressure. There is decreased heart rate, that is bradycardia. Then central nervous system, you will have decreased concentration, general lack of interest, or patient can have depression. In gastrointestinal system, we have decreased GI motility and constipation. Constipation is also very common in hypothyroid. So in OPD, if you are suspecting hypothyroid, these are the complaints that you will ask, like cold tolerance, constipation, these things. Then in musculoskeletal system, you have muscle stiffness, cramps, pain, weakness, myalgia. And in renal system, you can have fluid retention and edema and decrease GFR. In reproductive system, as I have already told you, there can be arrest of pubertal development. The patient age is less. There is reduced growth, so there is growth retardation, and then menorrhagia, amenorrhea, anovulation, and infertility in females. And then in metabolic point of view, there is increased level of LDL and total cholesterol, and or individually or both elevated LDL and triglycerides as well. Then in skin and hair, there could be thickening and dryness of skin. The hair could be dry, coarse, and patient can have alopecia. There could be loss of scalp hair and or lateral eyebrow hair, as I've already described. You can see some, patient can have goiter, patient can have hypothyroidism, impaired mental and physical development. These are tuberous lymphoma, and this is xanthelasma because of increased lipid level. This is edema of limbs, solid edema and xanthomata. Then mixed edema with keratonemia. You can see the yellowish hue of the. Then if the patient has presented with hypothyroid or thyroid disease, it can have secondary cause in pituitary and other things also that you will see. This is a case of pleural effusion in case of hypothyroidism, which sort of resolved with the treatment, and it appeared again when treatment was left. This I have already told you earlier also. So there could be other comorbidities or associated conditions with thyroid. As I have told you, all the conditions like hypercholesterolemia, cholesterols are raised. Patient can have depression, very common. Then patient and present with infertility and menstrual irregularities, and patient can have other autoimmune diseases like diabetes. So just few words about hypothyroidism and hypercholesterolemia. You will see that 14-15% of patients with elevated cholesterol, like dyslipidemia patients, have hypothyroidism. So if any dyslipidemia patient comes to you, you have to investigate for thyroid also. And reverse is, you can see that approximately 90% of patients with overt hypothyroidism have increased cholesterol and or triglyceride level. That means it is one of the prominent manifestation of thyroid. So if you are working upon thyroid patient, you must look for cholesterol level. Just giving the anti-thyroid drug will not help. If it lowers, if the levels are less, it can be reversed with anti-thyroid, but otherwise it might be needed. Then lipids, I have already described you. I will not go to LDL-C levels increases with increasing hypothyroid severity. Then effect of thyroxine therapy on hypercholesterolemia. You will see that the decrease in total cholesterol achieved with thyroxine replacement in patients with subclinical hypothyroidism may be considered. And if this does more, and this will also reduce the risk of cardiovascular illness. So hypothyroidism is frequently associated with depression. I have already highlighted these points, so we will not repeat it. So there are few features that are common to depression and hypothyroid. So pure depressive symptoms, decrease of sleep, suicidal ideation, weight changes, delusions. Frequent hypothyroid changes, bradycardia, cardiac and lipid abnormalities, cold intolerance, hair and skin changes, delayed reflexes, presence of goiter. And the common symptoms that can occur in both are constipation, decrease in concentration, loss of libido, depressed mood, diminished interest in work, weight increase, and fatigue. So thyroxine in depression, you will see that thyroxine therapy is recommended for patients with depression who have persistently elevated serum TSH. So for psychiatric people also, it is required to work up for TSH in case of their patients. Then antidepressants may be less effective if thyroid functions are not normalized. So you have to take care of this. Then, as I have already told you, that hypothyroidism is associated with infertility. It is the basic test in infertility checkup. You have to, check it, and if it is there, you have to treat it. Then, if there are equivocal results of thyroid thing, you can, begin therapy and discontinue if no pregnancy for several months. So, in gynae, you have to suspect hypothyroidism if the patient has amenorrhea, oligomenorrhea, menorrhagia, galactorrhea, premature ovarian failure, infertility, decreased libido, precocious puberty, or chronic urticaria. You will see that many of the patients are referred from gynae. Patient has primarily gone to gynae for infertility or other complaints like amenorrhea, oligomenorrhea. They do thyroid, and then the patient referred to endocrinologist or physician for treatment. This is very common. Then hypothyroidism, when it is of autoimmune etiology, it is associated with type 1 diabetes mellitus, which is an autoimmune disease. So in diabetic patients, examine for goiter, and in TSH measurement should be done at regular intervals. So in short, algorithm for hypothyroidism, you will see you have to measure TSH. When TSH is elevated, you have to measure FT34 if it is low. So TSH is elevated, T4 is low. It is primary hypothyroid. On further working, you have to look for anti-TPO antibodies. If it is positive, it could be Hashimoto thyroiditis. In that case, you have to replenish the T4, or if it is negative, it could be other. If TSH is raised but T4 is normal, there is the case of subclinical hypothyroid. Subclinical means clinical manifestations have not come. Parameters have been raised. This means TSH is raised. So hypothyroid is there, but clinically it is not apparent because T4 is normal. Clinical symptoms will appear when T3, T4 will alter. So T4 is normal, so there will be no clinical symptoms. This is subclinical hypothyroid. You have to treat few cases. You need to treat few cases. you might not need to treat frequency. Like if it is more than, TSH level is more than 10, you have to treat. If it is in between 5 to 10, in that case, you have to look for TPO. If it is TPO is positive, then treat in between 5 to 10 also. If it is negative, then you can wait till level is more than 10. So annual follow-up is required in case of negative patient. If TSH is normal, then you can, and hypothyroid is there, that means you can see that causes is above the thyroid. That means it is case of secondary hypothyroidism, and then you have to deal accordingly. Then hormone replacement, what is the goal? You have to normalize the TSH value regardless of the cause of hypothyroidism. If you make it normal, the symptoms will, decrease and even go. Then treatment, once daily dosing is the rule, and that too empty stomach, very important. All these patients are taking empty stomach. When I are taking the history of thyroid, now you have to use this point in your history taking. Do you take any drug for thyroid in empty stomach? Like patient knows takes some drug, but you don't know whether it's hypo or hyper. You want to ask from history. If he takes drug empty stomach, it is drug of hypothyroidism, levothyroxine. If it is taking 2, 3 times, 3 times, not necessarily, not before breakfast, that means it could be hyper. So these are the basic things. The use of these drugs and timing schedule that you can use in while taking history. So monitor TSH level 6 to 8 weeks after initiation of therapy. Duration that also you have to remember. Don't get it done every 1 week. Like you have started treatment, come show me next week it is responding or not. No, at least 6 to 8 weeks. Give time, then you start changing doses depending on the TSH level. So only TSH level is required in follow-up, not T3, T4. So hypothyroidism is because of many causes, but there's only one treatment, which is levothyroxine. And then you have to take care that it is, branded thyroxine is recommended. You also have to take care that brands are not changed in between, and there are no divided doses. There are no divided doses in case of thyroxine. Only one dose, that is empty stomach, has to be given. Elderly patient, then doses can start with smaller doses because thyroxine causes heart abnormalities, and these patients are start with. It depends on if the severe dose. If malabsorption is there, in that case, patient will require more dose. And this has to be given empty stomach. That is very important. I'm again highlighting. And then in pregnancy, the dose of hypothyroid is, like suppose the patient was hypothyroid from the beginning, then you will find that in pregnancy the dose is increased. How it is safe in lactating mothers. Then if there is presence of cardiac disease, patient might require lesser dose and start on alternative also. In hypothyroid treatment, you have to normalize TSH level, and you have to start with low and go slow. Starting dose for healthy adults less than 50 years, dose is 1 microgram per kg per day. It comes out to be 50, and then starting dose of healthy patient more than 50 years, you have to start with lesser dose. If heart disease, you have to be cautious. So how does the patient improve with the treatment? Patient starts feeling better in 2-3 weeks. So if the patient calls you, sir, 2 हफ्ते, 1 हफ्ता हो गया, कुछ भी नहीं हो रहा है, just reassure him that it will take time, but it will get better. So patient starts feeling better in 2-3 weeks. Reduction in weight is the first improvement, followed by facial puffiness, and then skin changes and other things that takes long time to regress. Then TSH starts showing decrements from the high level, and TSH returns to normal eventually, and the dose you may fix on that. Then this is the levothyroxine is thyroid hormone, basically replacement of thyroid hormone. So if you will give it in excess, it will lead to conditions like their conditions in hyperthyroidism. So it will result in reduced bone density, osteoporosis, tachycardia, arrhythmia, AF, which is generally associated with hyperthyroidism. And in elderly diseases, in elderly patients, it can result in heart disease, CHF, angina, arrhythmia, etc. Or if it is under replacement, then you can have continued hypothyroidism and long-term end effect of hypothyroidism you can see, and there is increased risk of hyperlipidemia. Just word about diet in iodine deficiency. In this, you have to give iodine salt. You also can give selenium replacement. It has better effects. You have to avoid cassava and cabbage, which is iatrogenic. You have to avoid formula milk, and you can give fish, meat, and milk and eggs. Like seafoods are very rich in iodines. Then special situations that can be asked from you in as special notes like subclinical hypothyroid. You just read from books. Then the condition of postpartum thyroiditis, which is the occurrence of hyper or hypo during the postpartum period when the patient was euthyroid during pregnancy. So who are the patients at higher risk? Type 1 diabetes patient with history of postpartum thyroiditis or other autoimmune disease, because autoimmune diseases are never alone in the body. If there is one disease, you have to look for other disease also, because autoimmune process is going on there, and it will affect different organs, giving rise to different diseases. So if anywhere there is one autoimmune disease present, you will look for other disease. Then you can also be asked about myxedema, in which, in short, just you will see that precipitant factors are infections, trauma, stroke, cardiovascular, drug overdoses, and diuretics. And signs and symptoms will include mental confusion, hypothermia, bradycardia, older age. There will be sodium, glucose may be low, CO2 might be decreased because of hypoventilation. Then in ECG, you will see the voltages will be low voltage complexes in case of thyroid. Just remember the ECG finding. Besides bradycardia, you can have low voltage complexes, very important finding. Then treatment patients should ideally be treated in ICU with T3, T4, that means thyroid replacement, hydrocortisone, passive warming, and volume management. Then you can also be asked to write in short note on sick euthyroid syndrome, where total T3 is reduced, free T3 is reduced, TSS is normal. TSS is normal, but thyroid is at fault. That is sick euthyroid. So clinically, patient will be euthyroid, but this thing will be reduced. So you have to remember in hypothyroidism that you have to should have high suspicion for hypothyroidism in the population where I have told you these are the at risk of hypothyroidism, like hypertension, depression, dyslipidemia, infertility. Then if there is growth and pivotal delay, if there is unexpected depression, then TSH, FT, T4 to confirm the diagnosis, you have used the 9-square magic that I have told you. Then all obese patients should be tested with TSH. All pregnant patients has to be tested. That is mandatory for in the clinical working of pregnancy. And then you have to test for in postmenopausal women, because there is prevalence of 15% in that. Then in treatment, you have to start with low dose and go slow. Use levothyroxine only, and it has to be taken always on empty stomach. These are just the reinforcement of what I have told you. And thyroxine has not to be given empirically, if like without workup, or if you suspect that something is there and hormones are normal, don't give it. Then just opposite of hypothyroidism, the hypothyroidism was because of low levels of thyroid hormone. Hyperthyroidism is because of high levels of thyroid hormone. So coming on to hypothyroidism, it is a hypermetabolic biochemical state like hypothyroidism, which is also a multi-system disease in which there is elevated levels of free T4 and free T3 or both. Fine. Then you should note at the causes, how to differentiate for the causes and what is the appropriate treatment. So causes of hypothyroidism include Graves' disease, which is a diffuse toxic goiter, both sides. Plummer's disease, which is toxic multinodular goiter. As the word suggests, toxic means T3, T4 level are more, giving rise to toxic manifestation, and there is multiple nodular liver. Thyroid. Then there could be toxic phase of subacute thyroiditis. What happens is thyroiditis, there is inflammation of autoimmune destruction of thyroid. So initially it releases the thyroid hormone which is there, stored there, and then ultimately it goes into hypothyroid. So the toxic phase of subacute thyroiditis will lead to hyperthyroidism. Then toxic single adenoma means single nodule. Then it could be because of pituitary tumors that could be seen in molar pregnancy and choriocarcinoma, where the production of thyroid is not, thyroxine is not in thyroid, but then metastatic thyroid cancers like cancers and thyrotoxic epithelial. This can also be asked in a short note, and because of other drugs like amiodarone, very important. Then in Graves' disease, it is the most common cause of thyrotoxicosis, as you have seen, in which there is organ-specific autoimmune disease. Organ-specific is for thyroid. The most important antibody in this case is thyroid stimulating and immunoglobulin TSI or TSA. So what happens? TSI acts as proxy to TSH. TSH stimulates T3, T4, so it acts proxy to TSH. So TSI stimulates T4, T3, T4 production, and this leads to increase in thyroid level and so hyperthyroidism. So they can also look for other anti-autoimmunity markers as well as other autoimmune disease like pernicious anemia, type 1 diabetes mellitus, myasthenia gravis, vitiligo, adrenal deficiency. As I have already stressed you that in one autoimmune disease in the body, you have to look for other autoimmune diseases. In Graves' disease, this is normal. You can see this is diffuse uptake of radioiodine in Graves' disease. Coming on to toxic multinodular goiter, it is the second most common cause of hyperthyroidism, which is seen more common in elderly individuals of long-standing goiter, and appearance is lumpy, there are multiple lumps because it is more than one. Patient can present with, however, milder manifestations like apathetic hyperthyroidism. Patient can have mild elevation of free T4, T3, and it progresses slowly over time. Clinically, you will see there are multiple form nodules, and on scintigraphy, I told you that is used for differentiating between the causes of hyperthyroidism. So you will see multiple hot nodules, and in between the nodules, you will have normal areas. Like these are the nodules, and in between, this is normal area. Then comes to subacute thyroiditis. Subacute thyroiditis is the next most common cause of hyperthyroidism, in which T4, T3 are extremely elevated because there is autoimmune destruction of thyroid gland because of viral infection. There is immune destruction and destructive release is there. So the preformed hormones just release, causing excess. And once destruction is complete, I told you that it will go into, finally it will go into hypothyroid. So one thing that you have to remember and that will differentiate from Graves' disease is thyroid gland at this point of time is painful and tender on palpation. This will differentiate it from Graves' disease. Then on nuclear scintigraphy, there will be no radio uptake in the gland. So not focusing on symptomatology, if you have to differentiate on this basis, then you can see on Graves' disease there is diffuse uptake, and in subacute thyroiditis there is no radioiodine uptake in the gland. And treatment, unlike others, this condition has to be treated with NSAIDs and corticosteroids. Then toxic single adenoma, in which there is single adenoma, which is hyperfunctioning follicular thyroid adenoma. It is benign monoclonal tumor that is usually larger than 2.5 centimeter, and it is the cause of 5% of patients who are thyrotoxicosis. Nuclear scintigraphy will show only a single hot nodule. TSH is suppressed by excess of thyroxine. So the rest of since TSH is suppressed, so the gland is the adenoma is hyperfunctioning, but rest of the gland is, thyroid gland is suppressed. So in which we will see single hot nodule. Then age and sex wise, you will see that Graves' disease is seen between 20 to 40 years because it is an autoimmune disease and it is common in that middle age. Then toxic multinodular goiter, you will see that it is more than 50 years, long-standing goiters. So patient had long-standing goiter, then this is there. So it is there in more than 50 years of age. Toxic single adenoma usually seen between 35 to 50 years. Subacute thyroiditis is because of viral illness, and then it can be seen at any age. The sex ratio is very important thyroid disease, to the level that these diseases are more common in females than males, to the level of 1:5, 1:10, 10 times, 4 times, 5 times. So these conditions are more common in females. I'll tell you one condition. In hyperthyroidism, there is condition like mimicking hypokalemic periodic paralysis. Hypokalemic periodic paralysis. One is autosomal dominant, which is seen in males. Then in this condition, thyrotoxic hyperkalemic. So thyrotoxic condition is there, and then hypokalemic periodic paralysis is there. In that case, although thyrotoxicosis was more common in females, but that condition TPP, thyrotoxic periodic paralysis, is more common in males. So on nucleotide scintigraphy, you can see this is Graves' disease. This is normal. This is Graves' disease, diffuse increased uptake. This is multinodular goiter. You will see different nodules, hot nodules, and area between them are normal. And this is single toxic adenoma, in which you will see single hot nodule, and rest of these are functionally suppressed. So coming on to clinical features, you always try to categorize the features, like clinical features that are resultant of that can occur with any type thyrotoxicosis. That means it is related to increased level of thyrotoxin hormones. Then those that are specific to the Graves' disease, that means Graves' disease is one of the cause of thyroid. So I have told you, when you take history, you also to take history of cause, related to cause. So indirectly, these are specific to Graves' disease, that means come cause related symptoms. And then there could be non-specific changes of hypermetabolism. Then common symptoms include nervousness, anxiety, increased perspiration, heat intolerance. In hypothyroid, you have seen it was cold intolerance. Here it is heat intolerance. Then there could be tremor, hyperactivity. So in hypothyroid, they are hypoactive. Here they are hyperactive. Palpitations. There is weight loss despite increased appetite. In hypothyroid, it was weight gain despite decreased appetite. Here in hyperthyroid, it is weight loss despite increased appetite. Reduction in menstrual flow or oligomenorrhea. Then just a few words about the differentials of weight loss despite increased appetite. Or the patient in this, like weight loss, increased appetite is there, but this sort of weight loss, in previous class also I have told that if a lean thin patient comes to you like in between 20 to 40, what can be the cause? One cause is hyperthyroidism. Other causes could be TB, HIV. So these could be the other causes, and type 1 diabetes. There are 3-4 causes in which patient may appear like emaciated, and obviously the other factors that is associated with them will differentiate between whether it is TB or it is type 1 diabetes or it is hyperthyroidism, but they are the differentials that will come in the history of weight loss to the level that patient appears emaciated. Then common signs will include hyperactivity, hyperkinesis, sinus tachycardia. In hypo it was bradycardia. Here it is sinus tachycardia, and it is dependence to arrhythmia and heart failure, like atrial arrhythmia and high AF, CHF. There it was in hypo diastolic raised BP. Here it is systolic hypertension. Then patient is also having wide pulse pressure. What are the differential diagnosis of wide pulse pressure? Hyperthyroidism is one of the conditions. Other could be severe anemia, atrial regurgitation. So these things that you have to remember. Then in hypo it was cold. Here it is warm, moist, soft, and smooth. There it was dry skin. Here it is smooth skin. So you will have a warm handshake. There is excessive perspiration. Palmar erythema could be there. There could be onycholysis. On eye signs, you can have lid lag and stare. There could be fine tremors on the outstretched hands, which is called Formet sign. And you can have large muscle weakness. Here you can have diarrhea. In hypothyroid, you remember it was constipation, here it is diarrhea. Then you can have gynecomastia. Then there could be features specific to Graves' disease, in which there is diffuse, painless and firm enlargement of thyroid glands. This is painless. In subacute thyroiditis, it is painful. Here it is painless. Thyroid bruit can be audible with the bell of the stethoscope. Where you will listen to the bruit? On the lateral border of the lobe of the thyroid. Then you can have ophthalmopathy in the as eye manifestation, which can be seen in 50% of cases. And these manifestations could be just sand in eyes, periorbital edema, conjunctival edema. Patient can have poor lid closure, extraocular muscle dysfunction could be there. Patient can have diplopia, proptosis, or pain on eye movement. So these things could be there in Graves' disease. And in dermatopathy, there will be skin or limb manifestation, which is seen in 20% of cases. That includes, or that is because of the deposition of glycosamine glycans in the dermis of the lower leg, leading into non-pitting edema associated with erythema and thickening of the skin. And this is without associated pain and pruritus. So if limb edema is there, you have to differentiate it from other edema like cellulitis and other things, because erythema is also there. So you will have to see that it is not associated with pain or pruritus. Clinical presentation, you will see in multinodular goiter, you will see that there are multiple nodules, and in Graves you will see diffuse enlargement of the gland. In ophthalmopathy, you will see the proptosis, see the lid lag. You can visualize the upper part of this whitish part. Then you can have periorbital edema and chemosis, and there can be severe ophthalmos, and you can have skin changes, colored plaques on the skin. You can see colored plaques on the skin, and then you can see in Graves acropathy. Then you can also have clubbing and osteoarthritis. On onycholysis, you can see. So there could be some non-specific changes because of systemic effects of thyroid hormone. This hyperglycemia, glycosuria, osteoporosis, hypercalcemia, decreased LDL and total cholesterol. These was raised in case of hypo, but here it is decreased. Atrial fibrillation because of hypertension, LVH, increased LV ejection fraction because there is hyperdynamic circulation. This is one of the differential diagnosis of hyperdynamic circulation, so it is there. Then high output heart failure can be there, and patient can have history of excess iodine, amiodarone, and contrast dyes in affected changes. So we will just consider, as I have told you, 9 square approach, that you have to look for values of TSH and T4 that will give you clue to the diagnosis. Like in case of primary hyperthyroid, you will see that level of TSH is low and T4 are high. If the levels of TSH is low but T3, T4 are normal, it is subclinical, because T3, T4 are not raised, so there are no symptom of hyperthyroid, but TSH is low, so it is hyperthyroid. This is sort of subclinical hypothyroidism. Subclinical hypothyroidism is more common to be asked in examination rather than subclinical hypothyroidism. So, as in hypothyroidism, you will see the algorithm. You will measure the TSH and T4, and if TSH is less, T3 is more, or T4 is more, you will see it is primary hyperthyrotoxicosis. And if there are features of Graves, in that case, you will see we have to treat Graves. If there are no features of Graves, then it is because of other causes. In that case, radioactive iodine will be done, and that will differentiate between single adenoma or multiple adenoma. And if there is low uptake RIU, you can see it is subacute thyroiditis. In that case, you will treat it with steroids. So if TSH is less but T4 is normal, it is, you have to measure T4. If it is high, then it is thyrotoxicosis. Otherwise, it is normal, then it is subclinical hyperthyroid. So this is how we will proceed with the algorithm. Then how will you make the diagnosis? As I have told you, the patient has typical clinical presentation. Patient has suppressed TSH. Patient has elevated level of T3, T4, which is markedly in Graves. And then you will go for thyroid antibodies if this is suspected. We will do for other tests like ECG to demonstrate cardiac manifestations, in which you can find tachycardia, arrhythmias, etc., and then nuclear scintigraphy to differentiate between the causes of this thing. And then symptom-wise, you need to give symptomatic relief. The patient is, hyperkinetic, hypothyroid patient, मतलब बिल्कुल बनाया हुआ सा मरीज आता है बस, ट्रेमर हो रहे हैं, पेशेंट रेस्टलेस है, hyperkinetic है ना, तो you have to give symptomatic relief. Then you have to give anti-thyroid drugs, which are the the options available are methimazole, carbimazole, propylthiouracil. Then you can also treat by radioactive iodine or by surgery in the form of thyroidectomy, subtotal or total. And as I have told you multiple times, subacute thyroiditis will be treated by NSAIDs and corticosteroids. So for symptomatic relief, you have to rehydrate the patient, and give beta blockers. Very importantly, for symptom control, propranolol most commonly given. If propranolol cannot be given, then atenolol and metoprolol can be given. Rate limiting CCBs can be given if beta blockers are contraindicated for the treatment of CHF and arrhythmia, and calcium supplementation has to be given if required, and sometimes lugol iodine solution has to be given for decreasing the vascularity of this thing. One thing that you will go through the drugs in the you must have gone through in pharmacology, you will revise it, but most important thing that you will remember is the drug methimazole is contraindicated in pregnancy, and propylthiouracil is given in pregnancy. So you have to keep in mind while when patient gets pregnant, switching over, switching back. So how long to give anti-thyroid drugs? The reduction of thyroid hormones takes 2 to 8 weeks. Right? You have to check TSH and FT3, T4 every 4 to 6 weeks. In Graves, these may go into remission 12 to 18 months. In such patients, these drugs may be discontinued and followed up for any activity further in course. 40% of them are experience recurrence in 1 year, and they should be treated for retreatment for 3 years. Then the treatment could be lifelong if it seems like when it's not responding, then they seldom need surgery, very seldom. Otherwise, they are most probably controlled on drugs. Then multinodular goiter and toxic adenoma will not get cured by these drugs, so they need RAI or surgery. Then radioactive iodine, it is not to be given in pregnancy. As I have told you, this is contraindicated in pregnancy, but those who are not pregnant, that can be given in case of multinodular goiter or toxic solitary adenoma. It can be given in Graves' disease which are not remitting on drugs. So it is a only minor proportion of Graves' disease that in which you might require radioactive iodine. So the effect is less rapid than drugs or thyroidectomy. However, it is effectively safe and does not require hospitalization. It is given orally as a single dose in a capsule or liquid form, and there are very few adverse effects. So it is quite safe, but you have to choose your patients correctly. Radioactive iodine not to be given in children and pregnant lactating women, and it is not recommended in patients with severe ophthalmopathy. Then surgical treatment may be done in the form of subtotal thyroidectomy or total thyroidectomy. Anti-thyroid drugs and radioactive iodine are very efficacious and easy, so surgical treatment is needs, or you can say practically only reserved for multinodular goiter with severe hyperthyroidism in children, where radioiodine cannot be given. Pregnant women who cannot tolerate drug, large goiters with severe ophthalmopathy where radioactive iodine is not to be given, and large multinodular goiters with pressure symptoms, and those who require quick normalization of thyroid function. So basically, choice of your treatment is very essential. Some dietary advice in hyperthyroidism, you have to, like in hypothyroidism, you have seen fortification of thyroid has to be done, maybe in common food items or taking those food items which are rich in dietary, iodine. Here in hyperthyroidism, you have to avoid iodized salt, seafoods which are rich in iodine. Then there are excess amount of iodine in some expectorants, X-ray contrast dyes, and other food supplements. You have to avoid these. Then the iodine. Okay. So just to summarize, this is the table showing the availability of investigation treatment that you already know by this time. Just a word about thyrotoxicosis factitia that can be maybe asked as short case, in which there is excessive intake of thyrotoxin causing thyrotoxicosis. Like patient has deliberately taken thyroxine, like drug of hypothyroid, and because of that, patient, presents to you. This is basically a psychiatric disorder because without psychiatric disturbance, patient will not do this. So this is basically a psychiatric disorder. Patient will take thyroxine, have features of thyrotoxics, will deny history. That may lead to, very frequently to wrong diagnosis or wrong treatment because you will, interpret it differently. So they have, these patients have thyrotoxic symptoms, but they don't have signs of Graves because it's not a Graves. Then high doses of thyroxine given will lead to TSH suppression, and this will lead to shrinkage of thyroid gland. So in that case, treatment is to stop thyroxine and give symptomatic relief to patient. So this is the, in short, few lines, and you can be asked as maybe short notes, 5-10 lines are sufficient. So this is what algorithm of a thyroid nodule I have already described in text. Like if it is low TSH, you will have get technician scan, you'll have hot nodule, and then I have already described. I will not take time. Anyways. So this was all what was about the hypothyroid and hyperthyroid. For few, cancers, you can see usually the levels are raised, but normal levels can also be seen with thyroid cancers. So you have to remember this. So coming on to any topic, you must remember the points that I have described in the beginning, that you have to take care of 3 C's. You have to describe the conditions in picture that you are given at the first sight, and then you have to explore the cause and explore the complications. You have to include both, all the 3 C's in your history taking, in your examination, in your investigations, and treat all of them. That will complete the case. So I think that's all for today. Hope to see you early in the clinics, and if you have any doubt, you can solve there. So that's all for today. Thank you so much.